Yes, nurse, and she did her certificate course in palliative nursing from Pallium, India. She has around 10 years of palliative care. Now she is heading the inpatient department. So she is a well-versed person in this field, especially from the nursing side. She is the apt person to teach the own management part. So welcome, Dr. Sreedevi and OT. Thank you. Good afternoon.
Myself Sreedevi, and today I'm dealing with the topic is pressure ulcer and fungating wound. All of you know, in palliative care setting, we are managing commonly the pressure sores and fungating wounds. Uh, so what is pressure ulcer or decubitus ulcer? Uh, it means is a localized injury to the skin and other underlying tissue, usually over a body prominence, as a result of prolonged unrelieved pressure. Uh, Most commonly, the pressure sore is developed in the bed-bounded patient. The patient will bed-bounded for a since too many years. That person will get most prone to get the pressure ulcer. So regarding the pathophysiology, how the pressure ulcer will develop due to the prolonged standing or prolonged sitting, prolonged lying down position, there is a chance of getting pressure for a long time. That time, the particular place blood vessel will collapse. That will affect the nutrition, oxygen supply, and tissue perfusion. It leads to tissue ischemia and hypoxia. The hypoxia leads to cell death. This prolonged stress will cause breakdown of skin. This is called as pressure ulcer. The risk factors of pressure ulcer. Uh, in which type of patients or how the pressure ulcer may develop due to the friction. If the patient is in lying down position, how to change the bed sheet or how to change the dress and all. We are planning to change the bed sheet and all. We shift the patient with bed sheets and all. It will cause the friction in the skin. It cause pressure injuries. Then next one is shear. How to give the position to the patient. That time we will position the patient with our hands. We will the hands may cause the some pressure to the particular area. It is called as shear. Next one is impaired sensory perception. In paraplegic patients under, their sensory function will affect. It will cause the impaired mobility, that is impaired physical mobility. It may lead to pressure ulcers or pressure injuries. Next, altered level of consciousness and fecal and urinary incontinence. If some patient will with altered level of consciousness, sometimes fecal and urinary incontinence may occur. That time the patient will lying down in this moist for a long time. That will cause the cell damage and malnutrition due to the protein and reduction in the body. It will cause the pressure ulcers. In dehydration, in dehydrated patients, sometimes it may cause the dryness. This dry skin, there is a more chance to prone to get the pressure ulcer. Then excessive body heat and advanced age. In old age people and the skin will be more fragile to get the pressure injuries. Next is common site of pressure ulcers. According to the position of the patient, the site are varying. Some of the patients are mainly in sitting position. That is, wheelchair-bound patients are mainly in the wheelchairs only. Some of them are in fully bed-bound, in a supine or side-lying position. In ICU and some of them are in most commonly in Fowler's position. So according to the position of the patient, it will varying the site of pressure ulcers. These are the different site of pressure ulcers. First one is heel, second one is scalp pressure ulcers. The next one is, third one is in the shoulder blade, and next one is in toe, small toe, and the fifth one is sacral region, and other is in the buttocks area. So we are going to detail about common sites. In supine position, the position of the body parts will be pressed on the hard surface. That is, in supine position, and the scalp will be contact with the surface. Next is shoulder, then elbow, buttocks, heel, and toes. In supine position, and the toes will be pressed on the foot end of the bed. That will affect the pressure injury to the toes. That is toes. Next, common site is of in side-lying position. Mainly side-lying position, the ear will be contact with the hard surface. Next, shoulder is there. Elbow, the outer side of elbow may be touched with the surface. Then hip, then knee outer side, heel, ankle joint, and inner side of the knee also touch with the other knees outer side. So it will also cause the pressure ulcer in these areas. Next, Fowler's position. Mainly this position is used for in ICU and all. So this in this head area is most commonly affected in ICUs, in shoulder, sacrum, buttocks, and heel. Instead of this position, we are using sometimes the oxygen mask and all. It will touch to the ear, pin of the ear also. That also causing pressure ulcer due to the tubing will cause some pressure to the earlobe. It also cause the pressure ulcer to that area. In this, so we have to change the position in alternative manner. Next, prone. In this, the prone position, the head is most common. Forehead will affected with pressure ulcer due to prolonged pressure. Next one is elbow, chin, chest area, then reproductive organs, and knee and toes. These are the most common areas in prone position patients. Any doubt regarding the position or up to this part? You can ask. Okay, shall we move on next slide? Next slide is stages of wound. What are the stages of wound? Anybody?
So you could say how many stages are there and what are the stages?
4 stages, okay. What about others?
So, any different opinion? So Rita ma'am said degree. So What do you mean that? That okay.
Okay. Here, the first stage, there are 4 to 6 stages are there. In starting and the 4 stages was there. Now it was updating day to day. Now it was up to stage 6. So first stage is all of you know. Most of them are familiar with stage 1 ulcers. Sometimes we neglect it with from our side also in stage 1 and all. So it is very common. It is a red or differently colored spot that do not blanch with the pressure. That is called non-blanchable blanchable erythema. That is stage 1. All of you know, all of you see the picture like this only the stage 1 will come. So there is a redness will be there. That is a non-blanching erythema. That is that red color is called non-blanching erythema. In second stage, partial thickness skin loss or shallow open ulcers into the dermis or serum filled blister. These two pictures are under the stage 2. That is, sometimes it may be precipitate as blisters in some patients. Some of them as partial thickness wound will be there. There is a shallow open to the ulcers into the dermis layer. That is called stage 1. First stage is non-blanchable erythema or redness. Second stage is blisters or loss of shallow open, skin loss, shallow open ulcers with into the dermis layer. That is stage 2. Stage 3 is full thickness ulcers. Along with the dermis layer, the deeper tissues also involved. That is stage 3, including the tissue damage. There is a tunneling also there. Tunneling is nothing but a narrow opening or passage way that can extend in any direction through soft tissue. All of you know about tunneling. Something like it's a narrow opening to the skin. We can measure the tunneling. During the assessment and we are detailed measurement will be taken for the tunneling wounds, and day to day it will be managed with the dressing and all. That is stage 3. Next one is stage 4. It is exposed muscles or bone tendons. It up to this only previously we studied and all. Stage 4, the exposed muscle or bone tendon fully we can visible with the bones or sometimes internal muscles also we can see. Next stage 5 is unstageable. Unstageable. This is the stage 5. The pressure sore is unstageable if it has slough or eschar on the top. Like these wounds, we can find out how much the depth is there. The outside the slough will be covered with the wound. Once we remove the slough, then only we can identify the depth of the wound. Otherwise, we can't. That is unstageable. The scar will be there. Next, sixth one is deep tissue pressure injury. It is like a non-blanchable deep red, purple or maroon discoloration due to prolonged pressure or shear forces, and tissue damage from inside out. That is stage 3 or stage 4. If the first time it will be seen like a deep tissue injury, When it will go, we will check it out means it will go to stage 3 or stage 4. That is deep tissue pressure injury. There are 6 stages are there. First one is non-blanchable erythema. Second one is, what is that? Second one is, anybody know?
Partial thickness,
Yeah,
skin
exactly.
loss.
Yeah. In third stage,
Sometimes with a blister.
Full thickness ulcer.
full thickness, including what will be there? There is a tunneling in third stage. Okay. Tunneling will be there. Next, fourth one is deep tissue will be affected along with muscles or bones. That is fourth stage. Fifth stage is Eshkar, and sixth one is deep tissue pressure injury. These are the 6 stages of pressure ulcers. Is it clear? Next, we are going to assessment. How to assess a pressure ulcer? In our side, most of the nurses will manage the wound care or pressure ulcers under. So assessment is very much important for the nurses also. So doctors and nurses must assess patient skin at each visit of the bedbound and wheelchair patient. We are going to home visit and at that time we must assess the skin also. Otherwise, we can't find out the skin changes. So, in every visit and every visit of the patient, so we have to assess skin as well as important as vital signs. Okay, so while assessing, what are the things we have to assess? First thing is assess the pressure points. We already discussed some pressure points are there for particular patients. Like that, we have to assess the pressure points. Assess pain associated with wound, whether the pain is there or not. If the once the patient is having bed sore means or otherwise any wound means, we have to assess the pain on that wound and manage the wound first, then only go for an wound management. Next one is assess the location, where the wound is located. Next, measurement of the width, length and depth of the wound. In every setting and every visit, we have to measure the width and length and depth of the wound for identify the how the management is working. Once we see the wound, first day of the visit we have to check the width, check the measurement and note it in the wound chart. There is a wound chart will be there, or otherwise if in your setting wound chart is not available means you have to stamp some body chart and you have to note the pressure areas and pressure zone and write it the width, length and depth of the wound. First day of visit. Next, we have to go for next visit. No, that time also we have to check like that only. Then that also noted in that paper and difference will be we can match with together and how the management was working. So we have to change whether there is a need of change of management means we can change the management, and if any consultation is needed means we can arrange the consultation. Like that we have to coordinate the management. Next one is stage of wound. While marking the pressure ulcers under, we have to identify the stage, but if the patient is having some bone exposure is there, so that is under stage 4 of pressure ulcer. You have to write there only. There is a 6 centimeter length is there, 6 centimeter width is there, like, and depth will be, the depth is tunneling. There is a tunneling means that is depth. So depth will be, we have to measure and note it in a chart. In depth, and we have to check the depth and all. We have to identify the clockwise directions and all. By sometimes the wound will be the central depth will be 6 centimeter, means the 12 o'clock means it is 1 centimeter. So we have to clockwise measurement also we have to write it in the paper. Then next is presence of exudate. Some wounds will be getting some secretions will be there, some oozing will be there. That is exudate. The type of exudate also we have to assess. Sometimes it will be bloody, sometimes it will be some serous fluid will be there, sometimes it will be pus will be there. So how it look like? Exudate is the presence of the exudate is there means if there is exudate is there means we have to identify the exudate type and color. Sometimes the quantity of exudate also we have to measure. And assess for tunneling. Already discussed how to identify the tunneling and measure how to take the measurement. That is under assessment area. So first, the site of the pressure ulcer, pain on the pressure ulcer. What is the, if the pressure ulcer is there means we have to measure stage of pressure ulcer, whether there is a exudate or not, channeling or not, and chart these things to the paper. Next one, the management. First, we have to remember that always medicate the patient for pain before wound care. If a patient with a severe pain in wound, don't go for dressing and all directly to that patient before pain management. So, first of all, pain management is necessary for that patient. First, manage the pain, then only go for wound management. Always remember in your mind, first one is pain management. In different type of wounds, different stages of wounds, there are different type of dressing or different way of dressing. So stage 1, there is what is the characteristics of stage 1 means we know that non-blanching erythema. So there is a the caregiver education is very much important to that stages and all. Teach caregiver to turn or position the patient, how we can give the position to patient in proper manner, and excellent incontinence control. If the patient is on bed bounded, so there is a sometimes incontinence will be there. It will cause the moist environment to the surrounding area. It causes the damage to the skin. So educate the caregiver to how we can control the incontinence. You can use some supportive devices for to avoiding incontinence and all, or otherwise you can use the CBD for urine incontinence. And next one is positioning. If the patient is a bed bounded position, you give a proper positioning accordingly. Most commonly, we are giving every 2 hour positioning to bed bounded patients. If they are okay with that, you can instruct them to give a proper positioning 2 hourly with excellent incontinence control. For the stage 1 ulcers, in second stage of ulcers, there is a partial thickness wound is there, we know that. So there is a normal saline dressing is needed for that type of wounds because there is a no chance of infection is there. That is a clean wound. We know stage 2 is a clean wound. So we have to clean the wound with normal saline, and normal saline dressing is enough for that. So say in stage 3 and stage 4 and unstageable dressings. If the unstageable wound and there is a slough will be there, sometimes it will be very hard like a stone. So there is first step of management is how we can soften the slough first. So we have to soften the slough or otherwise we have to the surgical intervention we can arrange. So if in our setting and all, we have to dressing with white petroleum jelly for softening the slough. Once the slough will get softened, we remove the slough. Cutting will be there. So we remove the slough and identify the wound type of stage of wound. Sometimes it will be stage 4 or stage 3. So identify the wound and act accordingly. And and otherwise the wound is sometimes it's clean after removing the slough and all. So normal saline dressing for cleaning. We can make the normal saline in our setting also. That is called homemade saline. And another one, sometimes while we removing the slough and there is a bad odor will be there. For reducing the bad odor and infection, we add metronidazole powder, mix it with a white petroleum jelly and spread over the wound to reduce the odor and infection to particular wound. Next one is Debrides. It is nothing but papanuria ointment. It is also help to soften the or removing the slough manually. The next one is a mega heel dressing. It's a nano silver colloidal silver ointment. It is a wound healing. It will help the wound healing. These are the management of pressure ulcers. Other than that, we also charcoal dressing also we are practicing. In sometimes it will help to absorb the malodors. So the malodor wound and all, we have to put some charcoal in the including the dressing and not directly to the wound. In between the dressing pads, we can place a charcoal and it will absorb the malodor. But otherwise, the room and all, we keep the charcoal in the room also. Avoid hypochlorite solution like povidone, iodine, and hydrogen peroxide. In our setting, we don't use the povidone, iodine, and hydrogen peroxide for wound management because it will cause the tissue injury also. In surgery consultation, we already discussed in slough and surgery we can through the surgical intervention, you can remove the slough and all. Otherwise, some deep tissue injury was there, means that is stage 4, stage 3 and all. There is surgical correction will be needed, like plastic surgery may be needed. Next one is negative pressure wound therapy. It's a most common technique used for the more secretion from the wound. So we have to put a suction catheter in the wound. It will be attached to the suction machine, and the negative pressure will collect the excessive fluid and secretion from the wound. Already discussed that homemade saline, how to prepare the homemade saline in our home and how to prepare the dressing supplies in our home setting. So how to prepare the normal saline means it's a ratio of 500 ml of water and add 1 teaspoon of salt and boil and cool and keep covered until needed. That is, we have to boil the 500 ml of water with 1 teaspoon of salt and boil it and cool it and store in a airtight container. Usually we are taking the pressures or as a clean wound, not a sterile wound. So that's why we can use the homemade saline in that pressure ulcer management. Next one is how to prepare the gauze and dressing pads. Take old cotton sarees or dhotis, cut them into the squares and steam them for half an hour to 1 hour in a steamer or some idli cooker, something as there. We can put it in a steamer and steam for half an hour to 1 hour, and it will be impregnate with the Vaseline or liquid paraffin, and it will applied on the pressure ulcer. Why we are using Vaseline for this wound means it will not sticky to the wound. So that's why we using Vaseline for the this gauze and all, for avoiding sticking to the wound. May stick to the wound means it will causing spot bleeding while removing the dressing. So avoiding these things, we have to use the Vaseline to that area. Other than that, it will keep a moisture environment to that area. Is it clear? Normally we can use 2 to 3 days for normal saline. Actually, some setting they are preparing normal saline like that. Before they are going to dressing, they take a 1 glass of water and 1 pinch of or otherwise 1 liter. If 1 glass of water means they take the 1 pinch of salt in 1 teaspoon on 500 ml means they take the 1 teaspoon of salt. Every 24 hourly they change the solution. Next one is prevention part. How can we prevent the pressure ulcers? But as a nurse, or otherwise, how to instruct a patient? Charcoal preparation.
So regarding the charcoal preparation, we will come to that question later. So once we finish the theoretical part, we will look into that question. Okay. So ma'am is asking about the prevention of pressure ulcers. The prevention is one of the major part for us, because whenever you have seen a bed-bound patients, we need to prevent pressure sore formation. So sister is asking, so what are the ways to prevent pressure ulcer? How,
Okay.
otherwise, what are the instructions which you have given to the patient caregivers for prevention of bed sore?
Mainly
Yeah. We can use air cushion, ma'am.
Okay, air cushion. Other one is cotton ring. Cotton ring. Position changing, oil massage,
Air bed.
air bed. Okay. Go through that. Like prevention of bed sore is, the first one is position change. Every 2 to 3 hours, the position change will be there. So the bed bounded patient, every 15 to 20 minutes for a wheelchair bound patients or chair bound patients. Then next one is manage incontinence and special surfaces like air mattress, water mattress, and pillows and cushions for adjusting the position. So next one is nutrition and hydration and exercise. Why means once the wound is occurred means it will help the protein rich diet and help to heal the wound easily. So nutrition is very much important. Sometimes the protein allergy malnutrition also cause the bed sores. So we have to look on the nutrition. So if the patient is having any nutritional delay means you have to supply that and all, and educate them to take the protein rich diet and include more water in their food. Including that, we have to tell them to do some exercises, and it will cause the relieving some pressure to particular area. The exercise will stimulate the blood supply. It will it will help to wound healing. Otherwise, other than that, it will help to pressure relieving technique also. Then next one is already discussed, already tell, so that massaging with liquid paraffin and white petroleum jelly. Some setting under they using oils and all. While using oils, there is a chance of getting ant bite and all. The oil will, the smell of oil and all, invite the ants from everywhere to that body parts, and that it will cause the tissue damage again. The ant bite will causing the, sometimes cause the pressure injuries or sometimes the wounds in the skin. So next one is wrinkle free bed. Though, so we already discussed that friction also cause the pressure injuries. If we use the wrinkles in the bed sheet and all, it will affect the extra pressure to the wrinkled skin or wrinkled bed sheet area, and so it will cause the pressure ulcers. Next one is nail care. Some patient is having dry skin with a lot of nails. Some might be causing the skin abrasions due to the dry skin. The itching will be there by using nails, and it will cause the pressure or some abrasion. It will cause the pressure injuries. So there is a criteria is there. Some prevention. It's a skin. S for supporting surface. So we have to careful that make sure your patient get pressure relief on proper supporting surface, like airbed is there, or sometimes the patient will be the electricity supply is very less in that area, means you have to provide a water mattress. Sometimes patient will get the cold and all due to the water mattress, means you have to change it into the air mattress according to the patient. According to the patient inside, we have to change the supporting surface. Then next one is skin inspection. According to the assessment, we have to regular skin inspection will be doing for that every patient's. Regular skin inspection requires overall bony prominence at risk areas. Caregivers must be able to pick up the earlier signs. We have to educate the caregiver to every day or every week. You have to monitor the skin areas along with the bony prominences and inform our team, and act accordingly with the patient, and keep moving. That is proper positioning and at a frequent intervals, and frequent posture changes. Next one is incontinence or moisture control. Bladder and bowel care. That is catheterization if needed, means we can catheterize the patient up to the wound healing. After that, we can remove the catheter, and we can give the normal pattern. And frequent change of dressing and diaper. According to the dressing, according to the wound and all, we can change the dressing. Sometimes the wound dressing needed for BD basis. Sometimes it is needed for OD, because some patients may have so much of secretion from the wound. That type of wounds may leads to severe infection and all. So we have to change the dressing as BD basis. And nutrition and hydration, we already discussed that. Patient must have right diet and fluid intake. We have to give protein rich diet, and give the tell them to encourage them to take the plenty of fluids. And engage the patient and family. In wound dressing and all, at the time of visit only we do the management, like wound dressing and all. Most of the day, the family will give the proper dressing and proper care to the patient. So engage the patient and family to a wound management is very important. So involve patient and families in pressure ulcer prevention first. Once we have to get a patient with a bedridden case, So we have to tell the family as well as the patient to take care of the patient, how to prevent the pressure ulcers. Sometimes there is no pressure ulcer is there. After so many months, there is a chance of getting pressure ulcer. So tell them to prevent the pressure ulcer by positioning air mattress like that. We have proper nutrition and we have to tell them to prevent the pressure ulcer. Develop a contract of care. Like that, we have to involve them also in the care. What can we do together to prevent the pressure ulcers? Patient information leaflets. Sometimes they not at all get our words and all in medical words and all. So we have to give a leaflet in their own language on their own predictions like that. We have to give the leaflets. In our language, there is some leaflet is there for a positioning and how to change the positioning, how to take care of the patient like that. We have to give a leaflet like this. In your language also, you can prepare like this in rotate in your setting also. Any doubt, you can ask.
Thank you, Sreedevi, for the wonderful presentation. Anybody have any doubts on that? Please ask her. So we have a video on that for prevention of pressure ulcer. We will show you later. So in the meantime, if you have any questions, please ask. Okay. So, Manjula ma'am, what did you ask? Any question do you have?
Ma'am, please explain management side. Management.
What the pressure sore management?
Yes.
Okay. So we have learned the 6 stages of pressure ulcer, right? The first one is non-blanchable erythema. The stage 1 is non-blanchable erythema. For that, there is no open ulcer, only the red color will be there. Once you apply your finger pressure on that area, the redness remains there. That redness will be there. That is non-blanchable erythema. So the management of stage 1 is prevent further pressure on that area. You have to prevent pressure on that area. If, for example, if the patient is having sacral area pressure, stage 1 pressure ulcer, you have noticed the stage 1 pressure ulcer at the sacral area, either you can put the patient in right lateral position or left lateral position. You don't put the patient in supine position. Right? That is how we can able to prevent pressure on that sacral area. So the management of stage 1 is prevent further pressure on that particular area. That is the stage 1 management. Stage 2 is shallow open ulcer or partial thickness, or the blister formation will be there. Once the blister is formed, definitely the skin will burst, no? The dermis layer will open, but there is no infection, only clean wound is there. Better you can use normal saline for cleaning. No ointment is needed. You can apply some white petroleum jelly on that area and cover the wound. So that is the management of second stage. Coming to the third, fourth, and fifth stage, if there is a black necrotic tissue there, like that is slough there, you can do the debridement, slough debridement. Or you can use that metronidazole, like malodor there, you can use metronidazole powder. So that is the metronidazole is one of the good agent for controlling malodor, because that is the drug of choice of controlling anaerobic bacterial infection. So metronidazole is one of the best medication for that. And other than that, there are many medications like ointments. Already Sister Sreedevi covered Debridase ointment and Mega Heal ointments. So if there is a slough, the small slough is there, then you can use Debridase ointment. That will help to remove the slough. Once the slough is removed, then you can use Mega Heal. Okay, so that will help to promote wound healing. And another important thing is charcoal. So one of you have asked about the charcoal dressings. So charcoal is one of the good agent for controlling malodor. So the charcoal dressing is also available, but the thing is very expensive, but our patient is not able to afford that much of cost. Then you can suggest some home remedies also. You can take a coconut shell and like a burnt coconut shell, and so make it a powdered form, and take one dressing pad, apply some Vaseline on that, spread some that coconut shell powder, and again you can put a dressing pad like a sandwich, and then you can put it on the wound. So that will, don't put directly into the wound. Once you clean the wound with normal saline, and then you can apply some ointment or anything if you want, you can apply to the wound. For controlling malodor, you can fill that, put a charcoal powder in between the dressing pad and cover that wound with that particular dressing. So that helps to control the malodor. Okay, and we will not recommend the hypochlorite solutions like powder iodine solution or hydrogen peroxide for cleaning these kind of wounds, because if there is a granulation tissues are there, that will destroy. Because if you apply that hydrogen peroxide into the wound, already there is a granulation tissues there, that will destroy. So that is why we don't recommend these kind of solutions for cleaning and dressings, because this is highly irritant. If you want to use powder iodine solution, you can dilute with normal saline and use. Okay. And these are the way we can manage the stage 3, stage 4 pressure ulcer. And coming to the stage 5 pressure ulcer, that is unstageable. Okay, if there is a black necrotic tissue on the top of the wound, we can't say the stage. We don't assume. You can, when you document, document it, you have to document it is an unstageable wound. Once you remove the slough or a eschar from the top of the wound, then only you can able to find out how much depth is involved. Okay, so that is stage 5 pressure ulcer. For that, you have to soften the black necrotic tissue like a eschar first. For that, you can apply some white petroleum jelly or Vaseline on the top of that area, so that the necrotic tissue will soften, so that you can able to cut it easily. The slough, the surgical debridement is one of the only way to remove the black necrotic tissue. Or before that, you have to soften the black necrotic tissue. After that, you based on the stages of wound and symptoms of the wound, and you can treat. Coming to the deep pressure injury, deep tissue pressure injury. So if there is a deep tissue already injured, we can't, sometimes the internal tissues will already damage and burst it out, because if you Notice that time also the internal tissues will damage. The subcutaneous tissues already damaged. Sometimes it will up to the muscle also. So based on the stages of wound, you have to treat. If there is a deep tissue pressure injury, also you have to try to prevent further pressure on that area. Okay, if you apply more pressure on that area again, the intensity will increase. Okay, so try to reduce pressure on that area. So that is how. So this is how you can manage these pressure ulcers, stage by stage. Am I clear? Any doubts?
No, ma'am. Thank you very much.
Okay, thank you. So, we have a video on prevention of pressure ulcer. I will show you first, and after that, if you have any question, we will take it. Thank you.
Bed sores are easier to prevent than to treat. Mr. Sanal Kumar, aged 35 years, is bedbound after a recent accident. Anita is his wife and caregiver. He is being visited by nurse Sumi at his home. Good morning, Anita.
Good morning, sister.
Good morning, Sanal. How are you?
Good morning, sister. I'm doing fine.
Good.
Sister, I want to ask you something. I've heard that people who lie long hours on the bed develop bed sores. I change his position 2 to 3 times a day. Is that enough?
That is not enough, Anita. I shall show you the ways to prevent bed sores.
Okay, sister.
It is very important to change the position every 2 hours to ensure proper blood circulation. If patient has been lying on his back for 2 hours, turn him to one side for 2 hours. Remember to put small pillows between the bony points of the knees, elbows and ankles to prevent pressure on the skin. You can also use folded sheets instead of small pillows. Inspect all the pressure points with a torch. This is very important to detect formation of bed sore early. In a bedbound patient lying more on his back, inspect back of the head, shoulders, elbow, sacrum and heel. If a patient is lying more on one side, inspect ear, shoulder, hip, inner sides of knees and ankle. If there is any color change in the skin, avoid pressure and moisture on those areas. Using oil or lubricant, massage the patient's back with both hands in circular motion, stroke upward from buttocks to shoulders. This will help to improve blood circulation, preventing skin dryness and cracking. Turn him on his back after 2 hours. Then let the patient rest in supine position for another 2 hours. Again, turn the patient in other direction and maintain the position for 2 hours. Repeat this cycle and continue perform massaging and inspection. It is good to use airbed or waterbed as supporting devices to prevent bed sore. Do not make the patient lie directly on the airbed or waterbed. Always use a cotton bed sheet over the airbed or waterbed. If wrinkles are present on bed sheets, the skin rubbing over the wrinkled sheets may cause friction leading to bed sore. So, always provide a wrinkle-free bed. In case bed becomes wet, change the sheet as soon as possible. Keep the bed sheet dry always. If there is urinary incontinence, place a urinary catheter. Nails should be kept short. Otherwise, scratching can cause damage to the skin. Never drag or pull on a bed-bound patient. If needed, patient can be lifted with the sheets. Healthy diet is important in preventing skin breakdown. Encourage the patient to take protein-rich foods like egg albumin, pulses, and groundnut. Drinking adequate fluids is important to maintain hydration of the skin. Patients using wheelchair should be made to lift their buttocks every 20 minutes. Use cushions for sitting on wheelchair. Inspect shoulder, buttocks, heel and ball of the foot. Hope you have understood everything.
Yes, sister.
Thank you. Hope this video is helpful to you all as you got a good idea about prevention of pressure ulcer. So again, one more question: debridement we can do or not? So definitely we can do the surgical debridement, but before that you have to make sure that the patient is having pain or pain-free or not. If the patient is having pain, you have to give some analgesics and make the patient pain-free, and then you can do the surgical debridement. In between also, if the patient is having pain, you have to give some local anesthetic agent like pipivacaine or silocaine. You can dilute it and spread it on the wound, and so that within 10 minutes the patients will get a local anesthetic effect. Then you can do the dressing. So that is also one of the important thing. We have to keep it in mind all the time. So
We
any
can
other,
get consent form.
ma'am, could you please repeat the question again? Your voice was breaking.
We can do the debridement. We can get a consent form.
Usually, we don't take the consent form because this is the like cleaning and dressing. The dressings every day. Can we take dressing consent for cleaning and dressing? No. Every day, we will do the cleaning and dressings without consent. So is also as a part of cleaning and dressing because there is a black necrotic tissue. There is a that we need to remove it. If you ask the patient for consent, definitely they will think, oh, it's a painful or there is a complicated procedure like that. So I don't think is the consent is necessary for slough cutting. Without consent, you can do it. Anybody have any other opinion on that?
If the wound is very deep on the first stage, then when we are taking the patient, they do the cleaning, then they may took the then we can take the consent.
For
Or
what?
if it is taking too much time for healing, then they do the skin grafting. That
Yeah.
time also we have to take the consent.
If you definitely if the patient is having third stage or fourth stage pressure ulcer, their health status is okay, then you can think about the skin grafting procedure. We usually include on surgeon into that patient care. We will take the surgeon's opinion. If the surgeons are agree, definitely we will go for skin grafting procedure. But if the patient is planning to undergo a skin grafting procedure, definitely we need a consent because the patient, we need a permission consent from the patient. But if you want to do the slough cutting or a cleaning and dressings, I don't think the consent is required or not. Consent is not needed, I think. We don't take consent for dressings, every dressings and slough cutting. Slough cutting is also as a part of dressing, so we usually don't take. Definitely. If the patient is planning to undergo a surgical procedure, then you can take a consent. But this is not a surgical procedure. You are going to remove the black necrotic tissue from the wound for promoting wound healing. If there is a black necrotic tissue on the top of the wound will not heal properly. So that is why you will be trying to remove the black necrotic tissue from the top of the area. So that is a part of cleaning and dressing. Any other questions?
Ma'am, you told no, Xylo can the for wound spread.
Yes.
That one repeat, madam.
Yes.
So some patient may reports that in wound site and pain, we are having severe pain in the wound site during the dressing time. So before dressing, we can apply bupivacaine or sensorcaine, available 0.25 percentage and 5%, 0.5 percentage. So it's a local anesthetic agent, and we can spread or instill the bupivacaine to the particular wound. Actually, we are taking 0.5 percentage bupivacaine 2 ml along with the normal saline. We have to add them together and instill to the particular site of wound. For the pain management, while applying that, we wait up to 15 to 30 minutes. After on, patient will report that I have pain relief, then you can do the dressing.
Yeah, thank you, Sreedevi.
Thank you.
From the pain session onwards, we have learned about the two different types of wound, nociceptive pain and neuropathic pain. If the patient is having neuropathic pain, your systemic analgesics may not help, so that you can use the local anesthetic agent. If the patient is having neuropathic pain, the superficial pain there, your systemic analgesics may not help fully. So that time, as Sreedevi sister said, you can apply some local anesthetic agent like xylocaine, xylocaine or sensocaine. You can take 2 ml and dilute it with 8 ml of normal saline, and you can apply on the wound. So within 10 minutes, usually within 10 minutes, the patient will get a anesthetic action like local anesthetic effect, and then you can do the dressing. So the patient will not experience any pain after that.
In stage 5 and all, it is not working because there is that tissue is there. We know that the stage 5 and all, there is slough will be there. While we applying the sensorcaine local application to the slough, means there is no impact on that. There is no absorption will be happens. There is no action will be there. So it's a if there is granulation tissue, means it will absorb the sensorcaine and give the good response.
If you touch the healthy tissue, then the patient will experience pain. If there is some black necrotic tissues there, the patient won't experience any pain. So, like you can remove the top black necrotic tissue from the top, so that the patient will not tell anything. But if you go into depth, the patient will say like, "Oh, I am having pain." Then you can use some local anesthetic agent. So, for acetic acid dressing, anybody have any experience on that? Acetic acid dressing. Anybody? No. So usually the some surgeon says like if there is a pseudomonas infection there, you can use acetic acid dressings, but we don't usually use that acetic acid dressing. We don't have any experience on that. But that is also one of the way to manage the pseudomonas infection, the acetic acid dressings. But we don't have any experience on that. We can move on with the case presentation. In the meantime, if you have any question on this, please put it into the chat box. So Sarah will be presenting a patient story today.
இங்கதான் வீடியோ ஆன் பண்ணுமா? நான் இப்பதான் கேஸ் பிரசன்டேஷனுக்கு
Video. Yes. If your network is good, you can switch on your video. Otherwise, you can switch off your video and present. Sarah?
Yes, ma'am.
Yes, you can start now.
Good afternoon, everyone. My name is Sarah Selvakumari. I am staff nurse. I am working in Leprosy Mission Hospital, Vadatarsalur. My patient age is 70, gender male, diagnosis wound management, pressure sore. Present complaints: fever with chills, bed sore over sacral region, breathing difficult, decreased in urine output, face and lower limb swelling. History of illness: diagnosed as a case of ulcer on left to lower limb and also known as a case of asthmatic patient since 7 years. He was bedridden few days before admission into the hospital. Bed sore found over sacral region by the time of his admission, pressure with slough and foul smelling. Examination: swelling on the face and legs, urine discoloration, heart clear, BP 120/70, pulse 78, respiration 26, SpO2 98, temperature 102 Fahrenheit. Treatment and signification investigation: IV antibiotic given, daily BD dressing, HB 9 grams, total count 8,000, platelet 7.7, RBS 157, serum creatine 2.26, blood urea 216, SGBT 35, ESR 126. Psychosocial aspect: the patient is married. He had 3 sons and 1 daughter. All are married. He is living in his own house. 5 years ago, he was worked as a fishing container. Now his second son is taking care of him. Medications: pressure sore medicines, tablet amoxiclav 625 BD, tablet pantoprazole 40 mg BD, tablet paracetamol 5 mg BD given. Asthmatic medicines, capsule epinephrine 100 mg BD given. Renal failure, tablet Lasix 40 mg OD daily given. Main concern: pain treatment, water bed or air bed position changing every 2 hours. Salt resistant diet given. 750 ml of water only per day. Used backrest given to maintain IO chart, maintain BP chart, family support. Summary: for bed sore, ulcers, sterile aseptic precautions, exercised slowly over sacral region about 15 into 10 centimeter and sterile dressing done. Antibiotics, anti-inflammatory and supplementary were given. Advised self-care method and educated his family about dressing and wound management. Nebulizer given. Discussion point: health education for pressure sore to the patient and family members. Advised salt resistant food, counseling given. Thank you.
Thank you, Sarah, for the presentation. Anybody need any more clarification regarding this patient story? Please ask her. Anybody?
Which staging can be done?
Ma'am? Remini ma'am?
Staging of the bed sore can be done.
Yeah, I think she has mentioned about the stage 4.
Okay.
Stage 5. 15 to 10 area. Previous, can you go back? One minute. Yeah, next. 1 minute. Next. Next. Yeah. Sorry. Sarah?
Yes, ma'am.
Yeah, are you there? Remini ma'am is asking about the stage 4.
Yes, ma'am. Fourth staging, ma'am.
4th stage.
Yes, ma'am.
Okay.
Debridement is done.
Okay.
The placenta ointment dressing done, ma'am.
Okay. So, where is the patient is still in the hospital or go back to the home?
Still in the hospital, ma'am. Our leprosy patient,
Okay.
2 month staying.
What is the physical status of the patient right now?
Patient condition is improvement is there, ma'am. But ulcer, limp ulcer also, ma'am. So
Okay.
to below the leg, below the knee, broad ulcer, ma'am.
That is the leprosy ulcer, no?
Yes, ma'am. Yes, ma'am.
Okay. Now we are focusing on the pressure sore ulcer today. You have mentioned about the stage 4 pressure ulcer on sacral area, right?
Yes, ma'am. Now improvement is there, ma'am. But sore ulcer almost healed.
Almost healed. Okay.
Yes, ma'am. Patient feeling better.
Okay. What did you done for that?
Dressing done, ma'am.
What? Sorry?
Daily the BD dressing only done, ma'am.
So, okay. What kind of things what kind of ointment do you use for dressing?
Placentex dressing, ma'am. Air cushion is used, ma'am. Position changing, ma'am.
Okay. Placentrex ointment you have used, right?
Yes, ma'am.
Okay. So, anybody have any questions or comments? Anybody?
Very deep and end stage sore, we can give hyperbaric oxygen therapy.
Yeah. Yes. Uh, could you please explain, ma'am, that oxygen therapy?
It's we have there is a center where in the oxygen is given the high concentrated rate. In that chamber where the patient's wound is there, that part is exposed, and the patient has to lie for maybe 10 minutes, 15 minutes, according to the concentration.
Yes, okay. So that is the another way of management of pressure ulcer. So you can give a high concentrated oxygen for that particular area so that the study says the wound heal will fast. So that is the another way of management. And again, you can use negative pressure that therapy. So that is the next way of management. You can use with the help of a suction apparatus also. The secretions, if you give that like apply a foam dressing on the top of the wound and the tubings will be there. You can able to adjust the pressure and time. So that suction apparatus will help to like that remove the exudate from the wound. And again, the stimulation, no continuous stimulation will give the improve the blood circulation so that the wound heal will fast. So that is also the another way of management. Okay. Any other things? So Sarah is that had a point on advised saltless food. How many of you agree with this?
Patient may be a chronic kidney failure, something like that, because face was having swelling plus leg edema. This patient may be a kidney disease patient, renal patient.
Okay. If there is a chronic renal failure patient there, we usually set like this. But on the other side, if you say like this, the patients will come with another problem like called hyponatremia. So that is another thing. Like a hypertensive patients, like if the patient is having a hypertension, they usually take doesn't take salt. They restrict all the salt that are containing foods, so that the patients will get hyponatremia. So here also you have to check the sodium level in between. Okay, so anyway, we have to ask the patient to restrict their salt intake. At the meantime, you have to check about the sodium level also. Here, counseling also important because the family members is also affecting with these all things because I think since last 2 months the patient is admitted in the hospital, right, Sarah?
Yes, ma'am. Yes.
Yeah, the family is also there, right?
Yes, ma'am.
Okay. So who is the primary caregiver?
We, son, ma'am.
Son.
Yes.
Okay. What about his wife?
Wife is old age, ma'am. That's why, ma'am.
Okay, son is staying, right?
Yes, ma'am. Two sons changing the duty. 2 days, day and night.
Okay. Okay. So here also you have to think about the patient family. From the day that first day onwards, the family is also suffering. Along with the patients, you have to give a proper emotional support to the patient and the caregivers, understand their emotions, and you have to. I think in between, if possible, you can tell the son for bring his wife and see his wife because that is also one of the important part here. So he is in the hospital. He wants to heal the wound. So he needs to. I think he needs to stay more days. In between, if possible, you can tell the son about that. What about others feel? Anybody have any other opinion? Anybody?
Madam, patient was getting only 750 ml water. That means the patient is a kidney disease patient, renal patient.
Yes, here the fluid restriction is also there. Definitely, we have to understand that this is a chronic renal failure patient. So we won't able to like output plus 500 ml you can give, no? So here the output is also less, so that the doctor will say like 750 ml. So from that we can understand that this patient is not that kidney is not functioning well. Definitely the renal failure will be there. So you have to discuss with the patient family about this. Sarah, did you talk to the family members?
Yes, ma'am. Son-in-law is coming, ma'am. Son-in-law only coming, ma'am.
Okay. Did they knows about the prognosis?
Yes, ma'am. Yes, ma'am. We are
They,
explained them.
they knew. right?
Yes, ma'am.
Okay. Okay. So there also the importance of conveying the truth is also the another thing. His wife knows about the prognosis.
Yes, she knows, ma'am.
She knows the prognosis. Okay. So I think you did well. You that thankfully his wound is healing well. Initially it was stage 4. Now and I understand that the healing process is good. Now the biggest worry is the leprosy wound, right?
Yes.
Yeah. So counseling also you already discussed with the family members, but even then you have to give some psychological support to the patient family. You have to understand their emotions, and also you have to talk to the patient. Is there any wishes or anything he wants? You have to fulfill his wish. So that all thing you have to look into.
Yes.
So I think we can wind up the session. Anybody have any more questions or any clarification? Uh, yes, nutrition diet is also important. We already discussed about that because the protein intake is one of the important factor for wound healing. So you have to encourage the patient to take a good protein containing foods. That is also important. For prevention is also that is one of the important things. So Sister Sreedevi was discussing about the small tip of prevention of pressure ulcer, WSKIN. So whenever you have seen a patient, the bed-bound patients, you have to think about the skin that protective device like a air bed or water mattress skin protection. Then the next S is skin inspection. We have to change the patient from one position to next position every 2 hourly. No, so if whenever we have turned a patient from one position to next position, you have to look into the pressure points. That is also the next thing, and also you have to give some massage so that the circulation will improve and we can able to prevent further pressure so formation. For that, you can use some simple moisturizing agent or coconut oil. But the thing is ant. So that we have to look into. And the next thing is K. K is keep moving. Every two hourly we have to change the position. The next thing is I. I is incontinence control. We know there are three major causes of pressure ulcer. The first one is unrelieved pressure. The second one is friction. The third one is moisture. So if there is a incontinence there is the patients will get pressure ulcer because of the moist. So incontinence control is also important. So you can use Foley's catheterization. If the patient is not willing to put a Foley's catheter, then you can think about diaper. So again, the diaper is not affordable. Then they can use their own sheet. But the thing is, if the linen will become wet, they have to change the linen as early as possible. And the last one is N, nutrition and hydration. So nutrition is and hydration is also very important. So these letters you have to keep it in mind all the time. And the next important thing is we have to understand that without caregivers, we can't do anything. So we need to respect the caregivers and we need to educate the caregivers, and we need to support the caregivers. We need to empower the caregivers for preventing pressure ulcer, and also if the patient is already have any pressure ulcer, our duty to prevent further deterioration. So that is also important. So we have to respect the caregivers. That is also important. And also, instead of you have to use the word we. So what we do, we do together. So that they can feel okay. They don't feel alone. So they feel that somebody is begging them to help them. So you can use. We need a teamwork. If they have a multiple pressure ulcer, we need maybe stage 3, stage 4 pressure ulcer there. Then you can think about to include a surgeon to that patient care, and you can take a surgeon's opinions. So our aim is to improve the quality of life. Okay. So that teamwork is also important here. Okay. So I think we can stop here. So thank you, Sister Sreedevi, for the wonderful session. Thank you, Sarah, for that patient story presentation. Thank you, others, for the contribution.
Thank you.
Thank you.
Thank you, Sister Sreedevi. That was wonderful presentation. Thank you. Thank you, Sarah, for presenting the case presentation. Thank you, Shikama, for facilitating. Thank you all for joining. Let's see you in the next session. Thank you.